Well, I apologize. It's kind of it's like the Boston Marathon. You're here for these long sessions, and now we're going directly. So if you want to stand up, stretch, go get a drink, or get a restroom break, please do so. But this is a very exciting session because it's not designed to be didactic. It's designed to be interactive. We have three components, and I'm going to ask the speaker to try to stick to the components. First component is to level set. What's the state of affairs in 2023 as far as endoscopic sleeve gastroplasty? So these are designed to be a rapid fire, get to the point, get us what we need to know about the field. Then we're going to transition. This procedure has been adopted globally. And we're going to transition to get an update from each of the IFSO chapters. Where is ESG in their countries or in their chapters, and what do they see as far as liabilities or access or scalability, insurance coverage, and what have you. And then we have expert panel that we're going to spend a lot of time in discussions, questions, and answers to kind of crystallize some of these concepts and identify what needs to be done, what's as far as research and as far as coverage and what have you. So with no further ado, it's my distinct pleasure to introduce Professor Eric Wilson from UT Houston. I call him my partner in crime. There's no study I would do without Eric Wilson. And we did the Merit trial together, and it's been a very good collaboration. And Eric is going to talk to us for the next 8 minutes on the state of the evidence on endoscopic sleeve gastroplasty.
Thanks, Baram. It's an honor to be here, and I appreciate being amongst a group of people that have worked very hard in endoscopic and primary endoscopic therapy. So the evidence for endoscopic sleeve gastroplasty was what I'm charged to talk about. Let me see if I've got this right. So, we won't belabor this. Most everybody in the room knows what ESG is. It's a restrictive gastric procedure. It reduces the volume of the stomach. We try to make it look like a laparoscopic sleeve gastrectomy, but it doesn't function like that. It delays gastric emptying. It's generally done in an outpatient setting, generally takes between 45 and 90 minutes. And it does preserve surgical options down the road, which is an important thing in a chronic disease. It has a long history. In earnest, it became the modern version of the ESG really began in about 2012 with multiple locations, and I'll go through some of that, but not a great deal. And then ultimately resulted in us needing and performing the Merit trial. So this is what it generally looks like. There is some preservation of the fundus, which is different than a sleeve gastrectomy. But you placate the stomach with preferential interest in trying to reduce the outlet at the incisura, which is a little bit different than a sleeve gastrectomy. The first trial we did, there were two trials in the United States that were started after the initial cases that were done, India, Panama, and at Mayo. The PROMISE trial was a multi-center trial with 20 patients, just a pilot trial to look at safety, feasibility, and then some data around weight loss. It was 20 females. We had no severe adverse events and weight loss of about 16 kilograms. This matched pretty similarly what Baram was performing with C.J. Gestalt at Mayo. And then after those two initial pilot studies, Manuel, who was involved in some of the cases that we were doing in Panama, propagated around the world, and Baram and Gontran, Lopez Nava, and Reem all got into this pretty aggressively and started generating significant amount of volume with multiple other providers. But this is just one of the retrospective reviews of 3 tertiary centers with Mayo, Weill Cornell, and Madrid with Dr. Lopez Nava, and showed 18-month data with percent total body weight loss between 18 and 20%. Ultimately, that resulted in the Merit trial being performed. Baram was the co-PI with me. These are the sites with all the gastroenterologists, equal mix of surgeons and gastroenterologists, and then Manuel was our trainer, and Natan ran our safety monitoring. So it was, the primary endpoints were an efficacy of at least 25% body weight loss at 12 months, and an SAE rate less than 5%. Multi-center, like we said, in both GI and surgical sites were involved in an equal amount. This is the slide that everyone has seen. We had a randomization of 2 to 1, and then a crossover of the patients that did not get the procedure, and then followed those out along with the patients that did for 2 years. So we had 2 years of data with 16% total body weight loss, a 77% responder rate. In this trial, that means we had a 23% non-responder rate who lost less than 25% excess weight loss. But very low safety, a very good safety profile with 3 SAEs that met grade 3 clavia-endo, 1 perigastric abscess, which was managed with endoscopy, 1 upper GI bleed, which was managed with endoscopy, and 1 malnutrition, which was also managed with endoscopy. So no surgical interventions from these SAEs. General adverse events really tied to pain and nausea, which subside relatively quickly. A significant improvement in comorbidities in the ones that we measured, in diabetes, the metabolic syndrome with non-alcoholic fatty liver disease, and hypertension. And also actually looking at reflux, because this does delay gastric emptying. That some of the thought was maybe that reflux could potentially be worse. It was not. These patients were not preoperatively endoscoped, but they didn't have extremely large hiatal hernias. That being said, small hiatal hernias were not excluded, and reflux scores on average improved, probably because of improved weight loss. This resulted in the Merit publication, which was published in Lancet, with Barham as the first author and me as the senior author, and ultimately an FDA market authorization. We've then gone on and had meta-analyses that have looked at this, and you see very consistent results around weight loss at 16% to 17% total body weight loss at 1 year and 2 years. So the 2-year durability data is with the Merit trial, and this has continued to come out. And then the SAEs tend to match as well, also about a 2% SAE rate across meta-analyses. We do have one study that looks at 5-year durability, but we need more patients. And so we can't honestly say what the 5-year durability is, but Ream did publish some 5-year durability data that looked pretty favorable. And then Brandon, who was here earlier, talked about patients with, he did a study looking at patients with higher weight, class 3 obesity, and had a 20% total body weight loss with those patients with a very good outcome, and this was also done in the US and Brazil. Apologize. So what about what can you do if they end up not being a responder to the treatment? You can revise them, and this has also been studied. It's been reported in literature. That stomach I just showed you was one of the original patients that was done in Panama. It ultimately got a sleeve gastrectomy 5 years later. What you basically need to do is you need to look and see the shape of the sutures, and if any sutures need to be cut out, and you need generally time, 1 to 2 years. What about comparing sleeve gastrectomy with laparoscopic sleeve gastrectomy or adjustable gastric band? That has been performed. Sleeve gastrectomy has better average weight loss compared to ESG. And lap band more closely matches ESG. This has also been shown in another study, and it also showed decreased adverse events and SAEs compared to laparoscopic surgery, so it's generally safer. Dr. Al-Qahtani did a large non-inferiority matched comparative study between laparoscopic sleeve gastrectomy and ESG, and saw that you had better weight loss with ESG compared to laparoscopic sleeve gastrectomy. So good comorbidity resolution, but low adverse events, and these can be revised. You can convert them to sleeve gastrectomies, or you can repeat them But generally, you do need some time and evaluation of the stomach in order to do that safely. So we're now at a point where we're approaching 30,000 procedures. Majority of procedures are performed by gastroenterologists, but a substantial minority are also performed by surgeons. So I would say that there's a growing body of evidence it's an appropriate primary bariatric procedure. We do need better durability, but at least 2 to 3 year durability is pretty well established. It's approved for BMIs between 30 and 50 by the FDA, but more studies have been performed in BMIs 30 to 40. ESG has fewer AEs and SAEs compared to bariatric surgery, but less average weight loss. And if you get an ESG and then consider surgery, in order to receive it safely, you need to be committed to getting an ESG for 1 to 2 years to allow dilation of the sutures. And thank you for your time.
Thank you, Dr. Wilson. Is Dr. De Palma here? All right, so we'll keep moving. So next is talking about the IFSO guidelines, and we have Dr. Christine Stier to give us an update on the IFSO guidelines as it pertains to endoscopic sleeve gastroplasty.
Thank you for having me. It's my pleasure to give an update on the IFSO guidelines because I'm very proud that a lot of the ESG statements were approved. So, my disclosures, the same like before. Why? You need to know what is the background for the reason for approval. And I took all the statements of Barham he wrote in the results book. ESG was launched first in 2013. And you can see it was nobody else than himself who launched it at that time. ESG gained global adoption, and if you look at this picture, this is the commercial from the media in Germany of a private company that even patented the gastroplasty as, with their name, as a weight doctor sleeve, whether it's done with Apollo or another device. It is accepted. And I will show you for which patients it is accepted, but we know for class 1 and class 2 obesity, of course. This is the MERIT trial. And as Barham wrote, there is a lot of literature out, more than 200 international peer-reviewed articles as of December 22 and before, and of course the MERIT trial in December 2022 was a milestone, an absolute milestone with a 1B evidence that was created. So, the IFSO guidelines itself, this was the background for the guidelines. The consensus conference was in March 2023 in Hamburg, where we have been. You'll see the picture. These were 43 experts from all kind of professions, surgeons, psychologists, endoscopists, integrated health professional. And we had 2 days to discuss this, and you see the program that was done for endoscopy. So it was about the MERIT trial, it was about treatment of adolescents with endoscopy, and it was about the metabolic challenging patient. So what was the results? First of all, there were statements with respect to the obesity classes. And the first statement that was approved with 78.9%, and remember, there were only 4 endoscopists, only 4. There were a lot of surgeons, but anyways, it was approved that ESG combined with lifestyle intervention is preferable to lifestyle intervention alone for the management in class 1 obesity. So far, so good. This is the MERIT trial, approved. It's also the merit trial that it is approved in class 2, but IFSO approved it. It's now an IFSO approved statement. There is consensus on class 1 and class 2 obesity. And there is consensus that patients with class 3 obesity can be treated with ESG endoscopically if they don't qualify or are not eligible for surgery. There was a consent statement on durability, and you just heard it from Eric. It's 12 to 24 months where there is evidence that this procedure is stable and provides weight loss. So individuals, oh sorry, I jumped, I'm sorry. I'm sorry, this is the wrong one. 12 to 24 months is stable. So there was a consensus on that individuals with class 1 obesity and comorbidities, ESG is superior, and there were some options, but for the consensus it was changed lifestyle. ESG is superior to lifestyle changes. It was approved by the experts. And this, the next point, is a point that is really important to me. This is the indication for the application in adolescents. The experts approved, and for me this is really, really a milestone, that ESG combined with lifestyle intervention is preferable to lifestyle intervention alone for the management in adolescents with class 2 obesity. And this is really important because what will you offer to adolescents with their long life expectancy? This is the best option you can give to those young patients with this lasting long life expectancy they have. So you should not recommend an ESG if the patient is not suitable for an individual that does not want treatment. Of course, if this is the case, you can't recommend an ESG. It was consented. I myself was a little bit sad about the fact that the expert did not approve the ESG for adolescents with class 1 obesity, but they did not approve it, so we have to work on that in the future a lot. There is a book that takes together all the results from all the experts and summarizes the statements and explains the presentation that were given. And this is the IFSO consensus book. And you see it, it's available here. It's printed already. And this is the algorithm IFSO approved with the expert in the consensus conference. So my conclusion and your take home is ESG is approved over lifestyle intervention in patients with obesity class 1 and 2. This is the merit trial, no question about that. It's approved in patients with class 3 that are not eligible for surgery, and it is approved over lifestyle alone in adolescents with class 2 obesity. And as I said, this is a milestone project. There is still evidence to be created on the durability, that it is longer than 24 months, and the indication of ESG in adolescents with class 1 obesity. And I really want to focus you on the last point. There is a joint consensus conference, either between IFSO and the World Gastroenterology Organization. So these two consensus conferences are very similar, but the last one is not very much promoted yet. So with that, I want to finish. We worked a lot, we considered a lot, we discussed a lot, but really we did also achieve a lot. Thank you very much.
right, so next talk is to talk about innovations that are coming with ESG. I mean, the technique is evolving, and hopefully we'll highlight some of these evolutions of that technique. If I could get my slides up, please. So these are my disclosures again. So for the purpose of this talk, again, the theme is pushing the boundaries. And the boundaries to be pushed is, again, medications are getting better. Our task as endoscopists and surgeons to make our procedures become safer. And then we're going to be pushing that paradigm because we do believe and we're convicted that the answer is in the GI tract. Therefore, this is what we're trying to push, and this is the boundary that we're going to try to continue to augment. So the first boundary is we now understand better how this procedure works. We talked earlier about it delaying gastric emptying and decreasing or changing the accommodation of the stomach to work on appetite pathways. And what you could see here is the antrum is a pump, and the shorter you make the antrum, the more you get a delay in gastric emptying. So that's the first innovation in this field, is we realize that this is before, these are the contractions that empty the stomach. You could see there's 3 of them initiating from the upper stomach. After the sleeve, they're still there. They're still strong and red. They're still 3 per minute, but now they're becoming shorter because they're originating from the antrum. So the question is, if we could make the antrum shorter, could we increase the delay in gastric emptying for better weight loss? And this is the ongoing randomized trial. This is the patient at 6 months. Our suturing technique is getting better. You could see, you don't see any loose sutures. The construct is very well intact. And this is including antrum reduction. So that we're starting about 2 centimeters from the pylorus. And now this patient achieved 23% at 6 months. So we're pushing. We're going from 15 to 16%. Now we're pushing the 20% margin with a very robust construct, and we will continue to move that equation that way. So now, remember I showed you MRIs. This is the antrum before the endoscopic sleeve, and you could see it's contractile, and you could see its volume before the procedure. Keep an eye on it. It's highlighted in bright because it's filled with Ensure that is radiolabeled with gadolinium. And now you could see that antrum after. Much shorter, it's about 2 centimeters, and you could see the imbrication of the entire greater curvature. And this is at 6 months, so we're improving durability and we're improving safety of that technique, and we're just because of better understanding of physiology. Technology is also getting better. Durability has been something in people's mind. And now we have platforms that could contribute to the enhanced durability. This is a study done with Dr. Mariam Al-Khatiri from United Arab Emirates. She's in the room, where we used the incisionless operating platform to imbricate the greater curvature of the stomach in a procedure called post 2.0 enfolding. And you could see that with each enfolding, we're able to reduce the stomach by about 14 centimeters. That means you only require about 6 to 8 of these plication, and now you could tubularize the entire stomach from the mid-antrum all the way to the cardia of the stomach, as you shown here. And this is the result of this. You can see here we're a couple of centimeters away from the pylorus. You have a tubularized construct with forces distributed by these nitinol baskets for durability. And when you look at the construct of the sleeve at 24 months in this multi-center study, you could see an intact, durable reduction. So again, our job is to continue to push this efficacy, durability, and safety equation in that landscape. Scalability is going to be another boundary that we're pushing. And with that, technology is improved, and now we have automated suturing platform that could increase or democratize access to suturing. So it's not only those who are technically savvy that could do this procedure, but the general endoscopist, whether a surgeon or gastroenterologist, could do these procedures. The third boundary is combination. Dr. Moore is going to discuss this, so I'm not going to belabor that point. So I'm going to just skip over these couple of slides. And then the final frontier is we know bypassed procedure, surgical procedure are the gold standard. How could we push to create a modular, whether endoscopic or hybrid endoscopic and surgical platform where we preserve the anatomy but recreate the efficacy and the metabolic benefit of a gastric bypass? The advent of single anastomosis bypass made this possible. So now you could create a gastrojejunostomy, whether laparoscopic, surgical, or magnetic. You could introduce restriction by creating an endoscopic sleeve gastroplasty. And now you could deploy an endoscopic device, like a pieces of Lego coming together, to bypass the rest of the stomach and the proximal small intestines. You have a modular, all components of a successful metabolic procedure, and you have not lost your stomach in that process, which is a big deal. That's what we need to be pushing in order to compete. So this is, once you create the gastrojejunostomy, if you know how to pull a PEC tube, you're basically pulling that device in place like a PEC tube. No x-rays, no special skills. This device is being pulled, whether you created the gastrojejunostomy surgically, endoscopically, magnetically, it does not matter, because once this device sits in place, it will bypass the distal stomach, and it will also bypass the intestines. There is no active fixation of that device because it's a system of springs and suspension, and it's floating basically and moving with the movement of the GI tract. And you could see here, this is articulating over the anastomosis, and the springs and suspension is keeping the forces on the antrum component and on the anastomosis component almost at zero because of that system. And then you could do it with surgical or endoscopic, and you could combine the modular system by adding the restriction with a gastroplasty attached to it. And here's that device sitting in place. This is the device bypassing the antrum. And there's the endoscopic sleeve gastroplasty on top of it. And the gastrojejunostomy is there. And you could see the entire components of a successful metabolic and bariatric procedure. And this is, again, the device on fluoroscopy, bypassing the antrum and articulating over a gastrojejunostomy. And you could see there is some tension over the spring suspension, because that will take a segment of bowel that's 75 centimeter and collapse it to allow this device to stay in place. So thank you for your kind attention. In our fields, you're always swimming against the tides, but if you persist, you will reach higher grounds than you've done before, and that's what we're doing with the field of endobariatrics. We're going to continue to push that equation. Thank you for your attention. All right, so next is, it's my distinct honor and privilege to present Dr. Natan Zandel. Dr. Natan Zandel has been the ambassador for anything endoscopic. He's been the motor and the brains behind a lot of this, and he is not an endoscopist himself. So hats off to Dr. Zandel, and he's going to talk to us about ESG, is it a tool for the surgeon, and how to incorporate it in the surgical practice.
Thank you, Barham, for giving me the most difficult talk. Especially the surgical side, you know, we are here, IFSO, even ASMBS, we're trying to support endoscopy, but at the end, we haven't fully supported, so we need to find a way to fully support endoscopic procedures. This is my disclosure. I'm going to go quick on some of this one because I wanted to make sure we understand that the first point in your practice is that we have so many people to do something, and we discussed it in the postgraduate course a couple of days ago, that if we don't do something, nobody's going to do something. So we need to make sure that we do this for even patients in the future that they are obese, that we want to prevent them to become morbidly obese. Also, Endoscopy show us, for me especially, the best evidence that metabolic interventions are possible without weight loss. And with surgery, we don't have that much. We have it with endoscopy, and I think it's something we have to go. We are trying to push for procedures and make a menu of procedures, but all of them have been around 20 years, 15 years, so we need to do something different. And we can use them, and we need to present this to the patient for primaries, for metabolic, and for revisions. So you saw the position statement. Now we just need to commit to the position statements. This is from Barham, because I like the way this is presented, because I think there is a big gap that we are trying to fill, but there is also a big gap of BMIs and metabolic issues that we're trying to find a way to fill for our patients. So endoscopy is gonna issue and it's gonna address some of them. But we need to be smart about it. We need to be smart about it in the way that either we do it or somebody's gonna do it, that's first. Second, if we wanna do something here, we need to do it ourselves and train our people to do it. So now that medications, and because I'm Colombian, I never say drugs, so medications are coming to town, they're not gonna go away. Better medications are coming. We just need to find a way to mix lesser interventions with medication. It's not one against the other one that it was presented the other day. It's not one against the other one. It's both together, fighting together, and help the patients together. So surgeries, yes, you see, we're trying to bring some, but they are 20 years old. Bring them. We're not competing with them. Manuel and the bariatric group from Brazil presented what you can do, many different things for revisions. And we had a question yesterday in a very nice competition that I'm not going to say that IFSO Latin America, we won, Marina. But in the competition, they asked why endoscopy and why not. And the reason why we should prevent endoscopy, because we already manage every complication with endoscopy, and we have the tools to do it. Through the societies, we learn what is the threshold for what we want to do. And we need to understand we have many different tools that we can add to our menu for our patients. I'm going to go quick to the merit because Eric presented, but I use the merit for a different reason than Eric. Eric was the academic side of I show this to the patients. I show this to the patients and tell them, you see, the results are this one. They can tell you whatever, this is the results. I know you like to hear from your neighbor and you want to hear from your husband, but these are the results. So you need to listen to our results, what we do metabolic and restricto, why if it's approved or not, because it's approved, and now the procedure is approved by the FDA, and then how many different ways to use it. Once you show them this, they understand that, yes, you're not lying to them. 5-year studies, compare with surgery. I don't compare them with surgery. I just want to understand where are we compared with surgery. Not trying to say it's better than surgery because it's not. So we can benefit practice, and this is the only paper that I know. I think my friend was here, but I don't see him anymore. This one, the top 10 paper in Miami IFSO last year. And the top 10 paper usually go to publication to obesity surgery, and they give even crap to publish it. Because most of the people who evaluate this are surgeons who don't do endoscopy and don't understand the significance. I will keep pushing for make sure that this paper is the paper that shows how bringing ESG and other procedures to your practice increase the number of patients in your practice. Not all of them are going to ESG. Some of them are going to end up in surgery, some of them are going to end up in nothing. But it brings much more patients to your practice, and that's what scares some of the surgeons, that they're going to lose their practice. Is the opposite. You bring it to your practice, you're going to have more patients in your practice. So you grow your practice if they're safe and effective, if they are supported by our societies and federations, if we have the proper training, and we will grow our practice with better menu, like any restaurant, with better results, and with very good multidisciplinary approach. Practice that dual may offer individual approach to all the different issues of our patients. We need to explain the patients the difference. Foley is a wine, Foley is a catheter. You decide how you use it. So yes, new procedures, intervention, combined approaches is one of the great marketing tools. That's what he asked me to say. But if you ask me, much more patients will benefit if we do that and bring them to our practice and offer all this variety in a chronic disease that need less big intervention combined with medication and multidisciplinary approach. Thank you very much, Bart.
Always very insightful, Nathan. Thank you. We saved the best for last, and we have a scholar, a friend, a key opinion leader who always gives you the balanced approach to everything. Dr. Rachel Moore will talk to us about ESG and obesity pharmacotherapy, a match made in heaven.
What a charming introduction. Thank you so much. Rachel Moore from Rose Medical Center in Denver, Colorado. And I say that with a big grin because that's a change for me. I hope all of you live in a place that you love as much as I love Colorado. Thank you so much for the interesting assignment. These are my disclosures. So the questions that need to be answered here, we have a hint of the answers, but we lack the rigor of scientific publications about something that's happening a lot on the ground in real life in our practices. Many people are using Marina likes to use the word layering. Many people are layering anti-obesity medications with endoscopic sleeve gastroplasty, and we know that it seems to be working well, but there are very few published studies about this. So the questions that remain unanswered, number one, are whether these two anti-obesity medications and ESG would be synergistic or better together. What drugs should we be using? Should medication be given before, after, or at the same time as endoscopic sleeve gastroplasty? And what should the timing be if they're not at the same time? And can combination therapy approach surgical results? So, as I said, there are very few published studies, unsurprisingly, from our friends in Brazil. The first one was a study of liraglutide, and as a reminder for those of you that may not be familiar, liraglutide is the GLP-1 agonist it's a daily injection, so it's been replaced by semaglutide to a certain degree. But in 3 outpatient clinics in Brazil that use similar procedures and follow-up methods, this was retrospective, and what they did was they offered liraglutide to patients, and some patients said no, and some patients said yes, and they matched someone that chose liraglutide with someone that declined, and recorded their results 12 months after their endoscopic sleeve gastroplasty, and discovered that ESG plus liraglutide had greater percent total body weight loss, 24.7 versus 20.5, and ESG plus liraglutide had greater reduction in percent body fat as well. Second study from Brazil, this one prospective, randomized, and double-blinded. And the paper includes a picture of the placebo injector that patients that were randomized to the placebo got. It's very, very elegant. 61 patients from 3 outpatient clinics in Brazil within 1 month of their endoscopic sleeve gastroplasty were randomized to get injectable semaglutide. Semaglutide is the GLP-1 agonist that's once a week rather than daily, like the liraglutide I was just talking about. Randomized to get semaglutide, or they were injecting themselves with a placebo, so the patient didn't know. ESG plus semaglutide had greater percent total body weight loss at 25.2% versus 18.6%, greater percent reduction of body fat, and a lower mean hemoglobin A1C as well. This is a graphical depiction of what I was just talking about. It's small, so for those of you that can't see, the coral or pink color is ESG alone, and the ESG plus semaglutide is the blue. And of note, I told you one of the open questions here is about timing. Of note, we've got the months running on the horizontal axis here, and it's several months out when they start to separate from each other. And so when to begin the medication is an open question. I want to thank so much. A couple of people shared not yet published data with me, including Cy Pishamol, who was in the room earlier and had to step to another session. So although she can't hear me say it, thank you, Cy. This was a big splash at DDW, Digestive Disease Week in the US, when Dr. Pishamol presented this. This was the single center retrospective on 224 patients. And what they did was they started looking at who had ESG, who had anti-obesity medications, and the way that they divided it up, they made 3 different groups. And so they used the word monotherapy for ESG alone. Combination therapy was defined as ESG plus an anti-obesity medication within 6 months. And then they used the term sequential therapy for ESG and anti-obesity medications that were more than 6 months apart. Now, in this case, the anti-obesity medications studied were a wide range of things: phentermine plus topiramate, orlistat, the GLP-1 analogs. It's going to be relevant momentarily. You're going to want to know that 30% of the patients did get a GLP-1 agonist among the patients that they were looking at. And the endpoint, they measured percent total body weight loss after 1 year. And this is her graph, taking you across the best responders were patients. You remember they defined combination therapy as getting an ESG and an anti-obesity medication within 6 months of each other. Best results, ESG plus a GLP-1 agonist within 6 months of each other. Second best, ESG plus any anti-obesity medication within 6 months of each other. ESG alone is the green column. That's what they called monotherapy. And then sequential therapy, the ESG and the anti-obesity medications separated more than 6 months from each other, performed less well. GLP-1 agonist is the best of all the performers, but in the sequential therapy, interestingly, the endoscopic sleeve gastroplasty and the anti-obesity medication afterward performed better than anti-obesity medication and then an endoscopic sleeve gastroplasty. And that's something to talk about as well. Also from the big meeting in the US, the Digestive Disease Week, Baram Abadiah's group presented the different anti-obesity medications, percent total body weight loss, and the results combined with endoscopic sleeve gastroplasty. And once again, you'll see the GLP-1 analogs are the winners compared with other anti-obesity medication treatments. And this too is unpublished data shared with me by a friend. So thank you for that. And so in summary, it's an evolving field. We're doing it a lot in our offices based on our observational results, but this is definitely something that warrants further study so that we can initiate best practices in the way that we're doing this. The GLP-1 agonists seem best so far. Dosage, duration, and other best practices are not yet known. Thank you very much for the opportunity to talk.
Thank you, Dr. Moore. Next, I'm going to ask Dr. Marina Curran, our president of ASMBS, to take over the next section of the program. And we're going to take a global tour on ESG in the IFSO chapters, talking about outcomes and limitation. We're behind schedule, so I'm really going to ask the speakers to stay to 5 minutes because we want to spend at least 15 minutes on discussion. So 5 minutes, we will get caught up because I think we're missing 2 of the chapters. So
we have subs.
We have subs, okay.
Subs, yeah. Okay. Sorry. Can I see that? Just for a second. Just 1 second. Okay. So, or is Chris here? Oh, there you are. Okay, so this is ESG across the IFSO chapters, outcomes and limitations. I'm really looking forward to this session. And to start this off, we have Dr. Chris Thompson coming to us from Brigham and Women's. Thank you. Harvard.
Thank you.
Uh-huh.
Oops. All right, thanks very much. It's been a great conference. So ESG in North America. Well, it's really been a banner year for ESG in North America, and particularly the United States. There have been some major studies. There's been some significant regulatory activity, corporate acquisitions, and increasing numbers of cases. Of course, we all know about the merit study. Barham did certainly a heavy lift here, and Eric Wilson and whatnot, and we were happy to participate. But this was a very, very seminal work here, and we're all aware of it. Randomized controlled trial, 209 subjects, 13.6% total weight loss 1 year compared to 0.8% for the control, and that got us the very much wanted de novo marketing authorization for the procedure. So that's the second milestone, I would say, for the past year. This was quite a big deal in the United States. This allows the device and the procedure actually to be marketed and for them to train the procedure. So we're going to have a lot more people doing this because now their hands have been untied and they can actually train the procedure. So 2 big milestones there. Third one, quick on the heels, was the acquisition. So Boston Scientific then purchased Apollo for over $615 million. So that was quite fantastic. And now, of course, they have the powerful sales force of Boston Scientific behind this newly approved procedure. We also presented our 10-year data at DDW, and this was on our first 7 U.S. patients. So that was done back in 2012 and 2013. And we used a bi-triangular pattern, so it was different than the U as the original pattern. And it was safe. And as far as the 10-year follow-up goes, we had a 13.5% total weight loss for these patients out at 10 years. And 2 people did require sleeve gastrectomies, and if you removed them, they still had a 12.9% total weight loss at 10 years in the remaining patients. So that was quite encouraging long-term data. There's also an increasing number of cases being performed, and it's interesting because there's a shift from academic centers into more kind of private practice models. This is exciting to see. There's over 2,000 ESG cases that have been performed in the U.S. so far to date, probably more towards 3,000. And that's larger than in 2021, where there was an estimated 2,220 and 1,500 in 2020. So clearly increasing numbers, and we're only going to expect to see that continue. There's also some competition that has been, kind of new to the United States, although it was around Europe for a longer period of time. And this is Endo Tools Therapeutics, an Endomina procedure, and this received clearance by the FDA. And you can see this device is familiar. It creates tissue plications, and there's different patterns that have been used. We did our first U.S. series in August of 2022. 12 patients, and they received a 15% total weight loss at 6 months. So very early results, but nice to see there's also some competition in the market when it comes to ESG type procedures. And finally, we've also seen activity around kind of augmenting the results of ESG. And this is a procedure called the GEM procedure, or gastroplasty with endoscopic myotomy. And what we're doing is combining an ESG with a pylorus-sparing antral myotomy to inactivate the antral pump and to further delay gastric emptying. We studied 6 patients prospectively, and they had a 19.5% total weight loss, and that's persisted out for 1 year now. And you can see the gastric emptying study, the half time went from 90 minutes to 204 minutes. And the GCSI scores, the only subscale that was affected was the postprandial fullness and satiety with no nausea or vomiting. So very encouraging results there, getting a 19.5% total weight loss. So in conclusion, it was a banner year for bariatric endoscopy in North America. There's been serious FDA activities, M&A activities, and a clear increased number of procedures. New technologies gaining traction, and it appears that bariatric endoscopy certainly is here to stay. Reimbursement, training, and credentialing issues now must be addressed. Thank you very much.
Thank you. I think we'll hold questions till the end. We're going to have Mohit Bhandari come up and do what's happening in Asia Pacific.
Thank you, Marina. Thank you, IFSO. Can I have my presentation, please?
It's Dr. Bandari.
Okay. ESG in Asia Pacific, I bring greetings from our center. This is in central India. Anytime you visit that part of the world, do come and see us. These are my disclosures. I'm a consultant to initially Apollo Endosurgery, now Boston Scientific. I work with Professor Manuel Galvao. He's a director of bariatric endoscopy services at my center. This is my case mix. So you see that good amount of experience with bariatric surgeries and endoscopic procedures, including the swallow balloon. And that's our growth trajectory. We started endoscopic sleeve program in 2017, and now it's probably one of the largest volume in Asia-Pac region. This is another disclosure. We recently had a coalition with one of the most famous endocrines in the world, Professor Arya Sharma, to develop a combination therapy with endoscopy and drugs, which is the future, obviously. Now, what is happening in Asia-Pacific region? We have seen that a recent study published by Asia-Pacific Metabolic and Bariatric Surgery Society involving 18 Asia-Pacific countries, it clearly shows that we have stagnated in terms of number of bariatric procedures in the Asia-Pacific region. And for some reason, the only one procedure which has increased in numbers is the one anastomosis gastric bypass in China and in India and in some parts of Australia. But overall, the number of bariatric surgical procedures have gone down or they have stagnated. Endoscopic sleeves have picked up, and it is becoming a viable option and alternative apart from the swallowable balloon to bariatric surgery in Asia-Pacific region. This study from Singapore, from the colleagues, they have established that they have done good number of procedures with around 15 to 20% of total weight loss, which is significant. Another study which we report is from our Chinese friends, and they also report that in China, at least 5 centers have started to do endoscopic sleeve, some of them being mentored by Manuel, some by other experts available, but China is slowly picking up in terms of number of endoscopic sleeve procedures. We have this paper from Japan. Kasama and his group and some others started doing, but they have just reached at the level of doing some initial procedures, whereas 3 or 4 centers in Japan are doing virtual training, proctoring from different experts across the world. This is from multi-center, from multiple centers across Asia, where again they have done a couple of procedures and they report very good weight loss with the endoscopic sleeve procedures. This is Nageshwar Reddy's experience. We have Rakesh here from his group. Extremely prolific group, doing a lot of work in the field of obesity, have been the pioneers in starting the endoscopic sleeve along with Amit Medev in our center in India. Now in Asia Pacific, if we see India, China, Singapore, Australia, New Zealand, Japan, Malaysia, Indonesia, South Korea, Philippines and Thailand perform ESG. These are the only countries where cases have been reported. I have gone through all the research articles, but I haven't found any country apart from this. And India leads along with Australia in terms of number of bariatric endoscopic procedures performed. The ESGs in Asia Pacific in 2019, as per published reports, were 5,000 procedures. And it is heartening to see that in 2020, we increased these number of procedures to 7,500. The growth of ESG in Asia Pacific region is really inspiring, and we are finding it as a very viable alternative to bariatric surgery and also to revisions in bariatric surgery. All the failed bariatric procedures are getting revised by endoscopy, and there are more and more experts who are coming and getting developed in this field. I would say that we need to understand that we belong to an area where we have a lot of NAFLD, number one. Number two, the diabetes comes to us in Asia Pacific region at a very lower BMI. So in India, endoscopic sleeve is now being reimbursed by insurance under EBT code, and we are permitted to operate a BMI as low as 27.5, which is just the latest regulation passed 2 days back. And hopefully, at this point of time, it's very limited, but we will be able to cover to tackle the disease called as obesity. I'm not going to go into too much of details, but this is my own data. We have done close to 1,000 endoscopic sleeves. I operate out of 4 different centers with Manuel, so around 680 at our center and around 300 plus at other centers. We have good amount of weight loss at 48 months. This is 18% of total weight loss, which we published already. A good 50% of excess weight loss, very good resolution of comorbidities. So nothing wrong here. This is our paper published in Digestive Endoscopy as one of the first Indian experiences. And now we have a 4-come outcome which we published with very good weight loss even at 4 years with endoscopic sleeve, which is very important. I've always believed that just like bariatric surgery, we need durability in all these procedures. Yes, there is a learning curve, and yes, there is an essential concern about the standardization of endoscopic sleeve, which hopefully with the group of experts in this room, we'll be able to achieve. I think I have limited time. Thank you, Marina.
Thank you. Okay. So next, we're going to have ESG in Europe, and we have a little change. Dr. Christine Stier is going to come and discuss what's happening in Europe.
Thank you, Marina. I substitute Gontran. He asked me to give this talk. Can I have my presentation? Okay, ESG in Europe. Gontran wants me to tell the story of ESG in Europe, and these are my disclosures as before. How did it begin in Europe? In Europe, we had really the advantage to have Professor Peretta with her training center in IRCA. This is unique how you can train there. And if you look at the pictures, you can see that there was even a trial where they examined with a protagonist named Manuel how is the best movement at the endoscope, which you can see on the right side. And we had several training centers in Hamburg, we were in Rome in the beginning, and we formed the first advisory board for ESG, the European Advisory Board. So Europe was relatively paramount in the development of the ESG. And of course, Gontran asked me to tell you that there was one of the first international meetings in Madrid, which was run by him, the Madrid International Bariatric Endoscopy, which first was in 2016. Who were the protagonists? In Madrid, there were two of them. The first, of course, was Lopez Nava, who published on that endoscopic sleeve gastroplasty for the treatment of endoscopy in 2015. He told me, Barham, I should tell you, he already started in 2013, I don't know. The other one was Dr. Graus, who did another kind of ESG because he had another suture pattern, but also very good results with that, and published on it in 2018, modified endoscopic gastroplasty for the treatment of obesity, both of those protagonists in Madrid. Of course, there's Strasbourg, as I mentioned before, and Silvana published also, or Silvana's group published also on ESG. Does endoscopic sleeve gastroplasty stand the test of time? A very, very important question. And what is important also, Silvana runs the registry, the European registry for ESG. And then there is Jamie Kelly in Southampton, who is also performing each year courses for colleagues to come there to learn ESG. And he published on endoscopic sleeve gastroplasty, a modified technique with greater curvature compression sutures. So he brings down the fundus with two sutures along the greater curvature and then does the U-shapes you saw before. And of course, in Italy here, there are also protagonists. The one is Ivo Boscovski, who sits in Rome at the Gemelli University. He published a lot also on ESG. The last one is redo endoscopic sleeve gastroplasty, technical aspects. So he's another very, very, very experienced ESG performer. And I really want you to focus that we do have a registry for ESG, which is located in Strasbourg and run by Silvana. So my take-home message for you, I was told to give you this. Europe has been instrumental in the development of ESG. To prove this, there is a European register headed by Silvana. However, the costs here are still out of pocket, and we must change this and convince the insurances. There are new companies that really make a business out of it. They are very, very well booked. And there is one exception, that is Italy. In Italy, it is covered by insurances. So thank you very, very much.
Thank you.
So our next speaker, he's not able to make it here, so this is a taped presentation, is Dr. or Professor Al-Qahtani. He's from Saudi Arabia, and he's presenting on ESG in the MENA region.
Thanks. Thanks for the invitation. We'll be talking about endoscopic sleeve gastroplasty in the Middle East and North Africa. And we'll show you different scenarios and experience in the region. Worldwide is growing, and in the Middle East and Africa is growing as well. In Saudi Arabia, we reached more than 4,000 cases, also in the other countries around us. We have done multiple training sessions and support in the region. And we have multiple countries performing the procedure nowadays safely. If you look to the procedure, just to understand what we are talking about, from outside, you can see how it will looking, but from inside, we are tubularizing the stomach in a way to make it very tube-like, as you can see here. If you look from the pre-pyloric all the way up, you will see the stomach reduced by 60 to 70% or around this. We have done multiple publications, both in adult and pediatric. We published our safety, efficacy, revisional, those lower BMI or overweight, which is a recent publication in this month. In those who are having BMI 27 to 30, still it's very valid option and effective in weight loss, and also in pediatric. In pediatric, we can see almost we have done up to 253 patients who underwent the procedure, and we follow them today up to 4 years follow-up with good weight loss. If you compare it to sleeve gastrectomy, you will find that it is within 10% total weight loss from sleeve patient. So if the sleeve lose 20 or 30, the ESG will lose 20, 10% difference. In terms of comorbidity resolution, they are very close to each other. At first event is so safer, and there is no significant statistical significance. Revisional can be revised to any type of procedure. If you look to also, this is a video to show the revisional where you can release the adhesion and you do the revisional in combined approach, endoscopic and laparoscopic. And this is a way to show it where you can remove the inside and you do your sleeve from outside. This publication also done to show it's safe also to do sleeve after ESG. Publication that you can do over stitch revising sleeve gastrectomy itself. Again here, you can do ESG after sleeve. And if you look how it looks afterwards, that's what you get, a very nice tight stomach after LSG. Because of the time, we are not showing you the video. Recently, we published in overweight, up to 13% total weight loss at 3 years. This is redo. You can redo the procedure. I don't have time to show the videos, but you can do the procedure multiple times, even 1 or 2 times or more as you need it. And you can do it after banding. You just go assist your stoma, endoscopic, and you go and execute your procedure. There is again a video. I'll try to show you part of it. where you go in the stoma here, and when you go in the stoma with your procedure and you do your technique, you will have endoscopic gastroplasty as such. This is also after biliopancreatic. If you go there and you see the stomach, huge stomach, as you can see, you see the stoma, you can narrow the stoma and narrow the pouch with endoscopic gastroplasty. So in conclusion, ESG is growing in the MENA as it is worldwide, shown to be safe and effective both as a primary procedure and as a revisional procedure. Thank you.
Thank you. Okay, so next I invite the update on what's happening ESG in Latin America with Grandmaster Flash of ESG. So Manuel Galvao Neto.
Thank you, Marina. You look gorgeous today.
Oh.
You as well.
Thank you.
So let's go there. That's my continent. That's the people I love. And we have a unique opportunity in Latin America because the training there and how the way we build it, we have this opportunity to be centralized. So we have quite some data on that and in the very reproducible training model. So that you have the numbers of people trained on the countries that are performing the procedure, 158 in Brazil, 6 colleagues in Chile, 7 Dominican Republic, 6 in Colombia, 6 in Ecuador, plus 2 Costa Ricans, 2 in El Salvador, 1 in Cayman Island, and believe me, there's more than banks there. And in Mexico, we really don't know because the device is not approved yet, but they are doing it. There's a lot of activity there, so we have to collect that data after. So it started in 2016. It takes a while to register the product in the continent, beginning in Brazil. And we now have estimated cases per year, 1,300, most of them done in Brazil. So around 5,000 cases were done in the region by now. And and that's I want to reinforce that. How was the training was done, at least in the first 100 colleagues batch? So we have a one-day course, a boot camp, a proctoring with technicians, and MD proctoring. So it means that to get into this course, they have to buy the equipment. The company will go inspect if they have the right equipment, and they need 3 patients to get into this course. So it means there's not going to be a gap in between training and proctoring. So that was a very unique opportunity on that. After that, the company has a presence in Brazil, and then it was a rep, and it changed a little bit because of money power. So we changed a little bit. So those colleagues come to courses abroad from their countries, Brazil, US, and Europe. Then the idea is that the local rep do a dry lab, and then they invite an MD proctor, and then they follow with proctor of technicians. And then also we had the opportunity to start in Brazil during the COVID, even publish the paper, teleproctoring, and prove that it's feasible to do teleproctoring on ESG. So you can see here our history through papers. So that's the very first one we did in ABC University. Very first cases we published in 2007-06, so it's there. And then we got our first paper with a limited experience group, and we have good results, 15% total weight loss, 2% adverse events. And then a more trained group with a more volume group, and then we got these more patients, almost 300, 233, 19% total weight loss, and 1 severe adverse event. And this got into this Brazilian consensus. And to remind you that the unique opportunity of training in the same way, all the I think it's 47 participants were training in the same way. So it got us with considered number of patients with 18% total weight loss at 1 year and just 0.8%. To know that this is the first paper that reports a death with the procedure. it was pulmonary embolism 7 days after, but we have to report that. And more, during COVID, as I told you, we have to stop, but we find a way to continue with the first teleprocuring paper we done, and I shake the hand of Dr. Jonathan Jerez almost 2 years after we begin this project. We have hundreds of cases. So that's it's a very interesting paper. And also, as mentioned by Rachel, Brazil pioneered the combination therapy. And Rachel, let me try to help your presentation. When you see that graph, when you use combination therapy, it is surgical results. 24, 25, 28% total weight loss, even on a randomized fashion. That is also a ratio presents. So you're going to see here, look at that delta. This is putting liraglutide, that is not as efficient as semaglutide, 5 months after. When you put just after, the delta is even more during this. So with that, I resume. This is the actual situation in the continent I proudly live in. Thank you.
I'm going to ask the panel members to come please to the podium. Dr. Mariam Al-Khatiri, Dr. Rakesh Kalpala, Dr. Roman Turo, Dr. Lena Ketan, Dr. Victoria Gomez, and Dr. Musa Khurshid.
No, I think it's updated. Is the update? Musa.
Is Dr. Vince Huberty here? No. No, you just please sit, yes.
He's going to stand, yes.
So if you have a question, please come to the microphone. I'm going to ask the panels to quickly just introduce themselves. What's their experience with ESG, and if they could tell us what's the barrier to adopting ESGs has been in their practice. Let's start with that, and then while people are thinking about questions. So we'll start with Victoria and move that way.
Thank you, Barham. Hello, I'm Victoria Gomez. I'm director of our bariatric endoscopy program at the Mayo Clinic in Jacksonville, Florida. We started the program in 2015. We offer both endoscopic sleeve gastroplasty, outlet reduction, and other procedures. I would say our biggest barrier is just the cost. You know, insurance companies are still not covering it in our area of the United States. Although now that we have CPT codes, we are pushing a lot more to try and get things covered. We've now been able to cover the intragastric balloon, for example, for our employees. So we're really working with the insurance companies, whether we need to send letters of medical necessity, lots of phone calls and meetings to make these interventions available to not only the people that serve our patient population, i.e. our employees, but then being able to expand it across the population.
So I'm Rakesh from AAG Hospitals, Hyderabad. So as I agree with Victoria, so the main thing is cost, and that's something which we have to work on. And if you can get the insurance covered, then that will be a big boom. And with the GLP-1 analogs as been described by other speakers, if you add on. So I don't say it's going to replace surgery, but it's going to be at par with surgery.
Hello, everybody. First of all, I would like to thank Dr. Abudaya for this kind invitation. It's my pleasure to be here among surgeons. This is Dr. Mariam Khatri. I'm consultant gastroenterologist, advanced endoscopist. I've been experiencing ESG since 2018, and we did almost more than 500 cases. Most of cases, we achieving 16% of total body weight loss. So still we are close to the international total outcome of weight loss. Frankly, we are not facing any problem regarding sponsoring the devices and the procedure. The procedure provided by the government for all Emirati patients. And now we are working, me as a task force leader for the putting the national guidelines for endoscopic procedure. And congratulations for having IFSO guidelines. I think it will be great reference for us to put it in our guidelines chapter. Thank you.
So we're all moving to United Arab Emirates, so start sponsoring.
I'm Musa Khurshid from Kuwait. So it's unfortunate we don't have, the government does not cover the cost of the device. So our main issue is the cost. It's about $3,000, much more than the price of a sleeve gastrectomy. So those patients who are not eligible for sleeve, so we have done almost 300 primary procedures, and we have got almost 50 revisional procedures after sleeve and Roux-en-Y gastric bypass. We're presenting our data tomorrow. We have 5 years results. Almost 31 patients eligible. We started 2017. So 30 patients have been followed for 5 years, and we have an average weight loss at 2 years about 14 to 15%, and total weight loss at 5 years about 12.5%.
Wow.
So we will be presenting our data tomorrow at the MENA chapter session. Thank you.
Thank you, Dr. Khurshid.
Hello. First of all, I want to thank again also Barham for the opportunity. This is Dr. Roman Turro, coming from Barcelona. I'm the director of the endoscopy, digestive endoscopy, bariatric and metabolic unit at Centro Médico Tecnon. I've been involved into bariatrics since 2010. Mostly of my practice has been with the POSE device, as I think that everyone knows about it. I'm like the kid of the POSE. So not anymore the kid, but anyway, performing probably in this last 14 years more than 1,500 cases. I would say probably the highest handicap is that I agree with the rest of my colleagues is the cost of the device. Nowadays in Spain still everything cash pay, and it's a little bit one of the major issues is the cost of it. And I also would add to maybe not for Spain because it's kind of easy to get the devices, but as long as I am also proctoring a lot of physicians with these new technologies, also the accessibility of the devices in different countries that they have the interest, but there's small companies, and I think that would be very helpful for the growing of the discipline is that if it was more accessible to different countries.
I have a question for the panel. I know Chris Thompson had brought up Endomina, and I have trained on the Apollo device. I'm just wondering how much easier is the Endomina, and who else is using it? Are you using it? Okay, that's for the POSE, right? It's the same device.
Well, it's a little bit different the device. I would say for me, of the three ones, technology-wise, the easier of manipulation. It is POSE because I've been like using it for so long time. I think that probably Overstitch is maybe a little bit the most complex one, but you get used to it. It's very, very, very easy. Also, maybe the Endomina is the youngest one of all the three technologies, so I think that there's also a little bit of work on improving on that. But cost-wise, in Spain, the most expensive one is POSE so far. Then Endomina and Overstitch, they are a little bit like similar. I guess that the rest of Europe, it is more or less the same.
So we do have a little experience with Endomina. In fact, we are doing a multi-center trial with Jack Devier. So I feel the learning curve is a little, Endomina needs the assistant also equally good compared to POSE and ESG where it's all self-skilled. So you need assistant and you need a little bit of more steps compared to these two.
No, we don't have the experience with my partner started with the Endomina in Kuwait. The beginning did a few cases, however, we've changed to Apollo Overstitch and he finds it much easier, even.
For me, I don't have that much work on Endomina, but I've been involved in, now we are starting a study for 20 patients. I think it's learning curve. It's once you practice it, you will know, you will be faster. But I think it's more relying on the assistant rather than you doing the procedure. For me, still attached to overstitch, and I think it's faster. And you control the time. You are not relying on your partner to have the expected outcome from the procedure. And still, money-wise, still I think it's expensive in comparison to the rest of equipment. I don't know about post-2, if it's how much it costs, but I know in comparison to overstitch, it's a little bit, the price is expensive.
We just started doing some training with Endomina. Comparing it to overstitch, my observation has been that I think it's maybe a little more ergonomic than overstitch for the endoscopist, but I think it's very also dependent on having a good technician or assistant.
So we're out of time, but I would like to ask one last question, and we need to tell us your worst complication in your experience. We'll start with Roman, and we'll work that way.
Why I have to be the first one?
Because it's complications.
Okay, let me think which one I had to, because thanks God I did not have like a lot of complications. I think that the worst ones, it can be like when you have issues with the device itself, that it breaks. And then like to remove some of those tools when they are broken, and then you cannot go and you can put back the grasper inside the IOP, or with if with the overstitch you can like not close the jaws. That's a little bit like scary. The other kind of complications, perforations. I mean, perforations. Thank God I did not have any one that I thought just like when I was doing the intervention. But bleeding or things like that, it's something that me as an endoscopist, I'm used to that, and it's more familiar. But the other ones, it's like a little bit like more scary, I would say.
Dr. Rashid.
Well, I'm honest with you. Almost 350 patients. Knock on the wood. We had only 2 patients. In the first 10 patients, both of them had post-operative bleeding, and each one of them required 2 units of blood. And this is because, we were not listening to Manuel. Manuel is my mentor. And he just tells me, just keep the tension, Musa. And we did not keep the tension on the thread. And that's why we had bleeding in 2 patients. We did not have any perigastric collection, no pneumothorax, or all, some of the complications we heard about. And then I went to the definition of serious adverse events. And then I looked it up, whether this is considered a serious adverse event or not. It is not. Okay. Patients did very well, and they stopped bleeding, this is our experience, thank God.
Thank you.
So far.
Dr. Khatri, and then we have a question, we'll take it for sure.
Yeah, we have done more than 5,000 cases. Thanks God, we have only 2 complications. One of them was with my mentor, Manuel Galvao, as well, when we tightened the lumen too much and we went for balloon dilatation post the procedure. And the other one, bleeding, and the patient, 1 week post procedure, he had COVID and he admitted in the hospital. He received anticoagulant and then bleed. I went to see the patient, gastroscopy done, and 1 clip sustained the bleeding. So that's it.
Thank you, Doctor.
So we have around 400 cases, so touch wood, no complications. Only once I had a spurter, and we could control with a hemoclip. So otherwise, no perigastric collections as described, we don't have any. Fantastic. And on that note, I just want to add the last question. So we have now a Society of Gastrointestinal Endoscopy of India. We formed a special interest group of around 7-8 people across the country, and for you are the chief patron for that.
Just this past year, I did a redo ESG on a patient that had a prior ESG 3 years ago, lost the weight, but regained some, didn't want surgery. And 3 days post-procedure, he presented to the ER with a gastric perforation and peritonitis. So he went straight to the OR, had a wedge resection. He was eventually discharged doing well. Interestingly, I mean, just to show you, I think it's very humbling because, you know, when we talk about placing full thickness sutures, so when the surgeon went in, I mean, he described there was a suture close to the heart. There was one at the diaphragm. I mean, just to show you just the proximity with what we're working with, you know, perigastrically, that we're very close to other very special organs.
Thank you all for sharing this with us. And one last question, and we'll conclude that session. You could just speak to it. Oh, sorry. Could you activate the microphone, please? Yeah. All right. Anybody could take it.
Yeah. So I think surgeons who are not, I mean, nay for endoscopy, probably you need to develop the skills of really controlling the scope. So probably if you are a surgeon starting endoscopy, a couple of 100 cases, you have to do the routine endoscopy. And then once you have that complete hand on the scope, then you can get onto that. But I think in a surgical hand, it's pretty easy to pass on the learning curve compared to a physician.
Yeah, so for the sake of time, there's published literature, the learning curve, they average between 20 to 50. I think the reality is after 50, you get very proficient and you will enjoy the procedure. The first 10, you will hate life and say, what the hell is this? And so it's anywhere in that range. So, all right, with that, thank you, everybody.
Thank you. Barham, don't forget your bag. Your bag. That has your tag in it. Okay, thank you. Thanks for this invitation.